Okay, well, welcome everyone. This is the number 17 Aspire Vascular course. And we've got three exciting presentations this evening from Bijan Modrai, Janice, Choi, and from Thanos Saratsis from Leicester. And this talk and discussion tonight is all about why should I consider a career in academic vascular surgery. I'm sure many of you have been exposed to academic vascular surgery, and really we're going to open the lid and give you a full exposure of exactly what a career in academic vascular surgery looks like. Just a few housekeeping rules. There's the opportunity to ask questions, and you can do that if you see at the bottom of your screen there's a Q&A box. If you complete that, then we'll do our best to answer each of your questions. So without further ado, we've got an hour or so to spend listening to the presentations and then having some hopefully useful discussion. So I'm going to introduce Bijan Modrai, who's the Professor of Vascular Surgery at Guy's and St Thomas's and King's. And for the next sort of half an hour or so, he's going to tell us exactly why you should consider a career in academic vascular surgery. Bijan.
Rob, thank you very much. I'm delighted to be able to be here with colleagues to present this subject to you. And I hope that over the next 25 minutes or so, I can touch on some aspects that colleagues, both junior and a bit more senior, consider when thinking about academic vascular surgery. And I look forward to the discussion. This disclosure slide is usually different. The disclosure for this talk, I guess, is that I'm an enthusiast and that I am an academic vascular surgeon. So when I was putting the slides together, I thought about perhaps two fundamental questions that we face in vascular surgery. One being the place of endovascular repair for treatment of aortic disease, and also the vexing subject of restenosis after treatment of lower limb conditions. And I thought, how far had we come to answer these questions? And perhaps not as far as we think. There is no doubt that research is fundamental to health outcomes. And there probably hasn't been as much transformative research in vascular surgery as we might think. Therefore, there is a real role for colleagues to consider research, to consider going into research as they are more junior, because the many unanswered questions remain. So there's no doubt that this is an important subject. I've known Rob for a while, so I'm sure he'll forgive me for this. The other thing that I thought about is just to illustrate what it means being an academic surgeon. Rob is an accomplished academic in the UK, and just to give you an idea of what it involves to get to where he has, he qualified from Bristol, I think it was 96, he'll correct me if that's wrong. He was an academic clinical lecturer, so he came through an integrated academic training pathway, which we can discuss a bit later. Clinical lecturer, and then moved to Bristol with these clinical academic interests. He's got an interest in the diabetic limb. His research interest is broader, clinical trials, new technologies, and evidence-based practice. And just some of the things that he's accomplished as an academic is really well-constructed NIHR-funded trials. Many of you will be familiar with the IMPROVE trial that answered the question as to whether endovascular or open repair is better when a patient presents with a ruptured aneurysm. He's an editor of the British Journal of Surgery and also the other activities that you can see there. So when you're thinking about the question of why should you consider academic surgery, I think it's really important to bear in mind what the reality of life as an academic is. And what is the reality? Well, first and foremost, you are a surgeon, so you have to manage patients and operate. You have a significant additional workload to my mind, which is to manage your day-to-day research. And that involves writing grants, writing abstracts, and publishing. And as you go through the years, you first learn how to research, you have to teach it, then you support others, and then you supervise. As an academic becomes more and more senior, then the role is more to do with management, and that comes with your expertise. There's a constant push to secure funding. Research cannot happen without funding, and that's a commitment that can't be overlooked. And when you're managing a department, you have to manage it with cohesion and make sure of outputs. And I think as an academic, it's also knowing your role within wherever it is that you're working and managing the expectations of the other colleagues. And in amongst all of that, what's called the scientific service, so meetings, peer review, and committees. So I think when one considers academia and academic surgery, through this talk, we'll talk about various degrees of commitment to academia. If you're a fully fledged academic surgeon, then this is what will be on your remit. So what about as a trainee? Well, I think the important questions when you're setting out in research are where to do the research, how to do it, at what time point it's most sensible to do it, and what to actually research. And it's quite surprising that in the different disciplines of surgery, the requirements for academia are different. So to obtain your CCT in vascular surgery, you have to have had 3 papers, 1 as a first author and 2 as either a second or a third author, and have made some presentations. And you can see that it's different for neurosurgeons, it's different for cardiothoracic surgeons, it's different for general surgery. And this is a recent publication asking why there should be this difference in different disciplines. So this is what you need to do as a minimum if you're set along the path of vascular surgery. And then you have to decide on a project. So audit is not research. And if you're good and if you're motivated, you will find that a number of people are likely to offer you projects, small projects, more significant projects. And I think the advice would be to be critical about what you take on. You know, if you're making more of a commitment, which is a 2 or 3 year research degree, then looking at the track record of who's going to be supervising you and the team that will supervise you and the mentorship that is involved is really important. But it's actually also important if you're taking on a smaller project that you might do over a year or over 6 months. You really have to be critical to make sure that you will be guided along the right path and that you will receive a decent output from what you've done. And then if you choose to do the project, for God's sake, commit to seeing the project through. There's nothing more disheartening than spending time on the project and seeing that nothing will come to fruition from it. Where to do the research? I think you have to think about the realities of working with the supervisor. It's about day-to-day support. And often it's more to do with who's in the wider team, or just as much to do with who's in the wider team that you're going to be working with as it is with the supervisor, the person who, you know, has the name for supporting research, so to speak. And part of that is track record. So if you're considering where to do your research, look at what funding and what outputs they've secured in the past. How many MD and PhD students have successfully completed and handed in their thesis? That you need to do a lot of groundwork before you decide where to do research. And also, I think hand in hand with that, if you're spending 2 to 3 years working on a thesis, whether you have any opportunities to enhance your clinical profile. That's not to be underestimated. So I've already touched on this. If you are setting up for a higher degree, then I think the preparation is key. I normally advise people to come and have a chat a year before they start their thesis, if at all feasible. Meet the supervisors, find out what's on offer Again, don't just take what is offered to you. And ideally, find something that you're interested in. It's a cliche, but I think if you're interested in the subject, then you're much more likely to want to devote time to it. Talk to the current students in the department. And there's no doubt that if you secure funding beforehand, it will make your life a lot easier. The alternative option is to accrue a salary from other means. Often it's from working as a locum whilst you do the thesis, but there's no doubt that that does take away from the main thrust of research work, and I'm sure we'll debate that. But funding, I think, does make the time you spend in research more productive. To my mind, it is better to carry out the research earlier in your specialist career. And again, I'm not talking about isolated projects. This is a higher degree. And I know that some colleagues do feel differently, and it would be good to have a discussion about that. But I think early is better, because you're more likely to benefit from the mentorship and advocacy that comes from having that exposure from a different team of people that you're with for 2 to 3 years. You're going to develop an interest. It will enhance your CV early on. I've talked about the clinical opportunities, and it will help you decide whether or not you want to be a career academic, and then to tailor the posts that you apply for related to that. So how to choose what you will research? I think you have to have a balance between novelty and feasibility. So it's no good being suggested a really fanciful, packed project full of unlikely work that won't succeed. That you could have some elements of that in your proposed work, but I think there needs to be a balance. There's no doubt that state of the art will make your project succeed and have bigger impact. You have to look at the strengths of where you're going to be doing the research and play to those strengths. Collaborators are really important. It will really enhance the work. And if at all possible, find out if there's been any independent peer review of the work that is proposed. We're all enthusiasts, and within the department that you're likely to be approaching, they will have enthusiasm for specific project-specific topics. Just be critical. That would be my advice. Okay, I thought I'd touch on 2 or 3 areas which I think are exciting to get into if you were starting out in academia now, and also areas that you could develop an interest in as a more senior clinician. So you've heard a lot about this. I really do think this has the potential to be transformative, data science. There is a lot of work emerging in machine learning, and I think that predicting outcomes and pattern recognition lends itself very well to vascular surgery. You can see that can enhance both diagnostics and therapeutics related to what we do. And again, this is a sexy term. You have to scrutinize the areas of research in which this is applied to, and whether or not it will be fruitful for the particular indications that people are trying to use it for when considering projects, for example. I think Thanos will talk more about trials and collaboratives, data science and clinical studies. I think this is quite interesting to see how machine learning can make the clinical studies that we do more fruitful, and may perhaps change our approach to how we do clinical studies. Wearables, those will I think they've already found their place in data outputs related to questions that we want to answer, and that will only increase in the future. And data extraction from hospital records. These were all a few points I thought I would note as interesting developments in data science that are only going to develop more as time goes by. The other area is imaging. I think, again, modern vascular practice is intimately linked to imaging. I think we'll move, you can see on the top left, there's a multiplanar reconstruction of the aorta that will probably seem quite primitive in 5 to 10 years' time, as a way that we have of doing things manually, so to speak. What I mentioned about machine learning and deep learning will no doubt be applied to vascular surgery in the same way that the cardiologists are starting to apply to the heart now, as you can see on the top right. And then involved with the computer science and imaging, I think that in silico modeling and mathematical modeling of disease will also be an area that will be exciting in the future. So, you know, just to flag a few areas of interest for trainees and more senior people alike. Janice is going to talk extensively about translational research, so I won't talk a lot about that. Just to say that these are examples of things that are going on in our department, and I think that we have a real niche as vascular surgeons to bring insight into the basic science that scientist colleagues engage in. So, you know, through collaborations, we've managed to take cells from mice to patients, used biomaterials to encapsulate cells, looking at gene damage in cells in operators who perform endovascular repair, looked at the cerebrospinal fluid from patients who have thoracoabdominal aneurysms to look for biomarkers and therapeutic targets for paraplegia, and then applied imaging and mouse models to the deep vein thrombosis model to predict which thrombi in man are lysable when patients present with deep vein thrombosis. And these sequences are now being used in patients. So just goes to show that that how important vascular surgeons are in providing the insight to basic science studies. I saw this term coined the other day, collaboration is the new competition. I think that's right. I think collaboration is now really coveted. And so for the work that you saw illustrated in the previous slide, the people involved are imaging scientists, computer scientists, neuroscientists, platelet biologists, biomaterial scientists, public health, England's involved, and also industrial collaborators. And they've really strengthened this work and increased its impact. Teams are important. Don't worry about assigning credit, and collaborate for better publications. I mentioned the integrated academic training pathway. You can see that it takes you through from academic clinical fellowships to clinical lecturers with various amounts of academic and clinical time divide. Note that if you are an ACF, at the end of your ACF period, you are not allocated funding. So your ACF period has to be devoted to some extent to designing a project and to accruing funding for that. So you're good to go, ideally. As an ACL, to my mind, you develop a new program of work that you follow on as an academic consultant. These jobs are coveted within institutions. We're increasingly finding it more and more difficult to secure them in relation to other specialities, but they are important for vascular surgery. They protect the academic time, and I think they've led to high quality outputs and the ability to secure funding. How do you secure funding? We're very lucky to have the British Heart Foundation in this country that's a specific cardiovascular charity. Many countries don't. And I would encourage interaction with the British Heart Foundation. These funding bodies, they covet surgeons, don't forget that. Bodies like the BHF, Wellcome, and NIHR offer fellowships. And if you start early with them, you can almost run through if you're doing well. As I said, collaboration is important. Get feedback prior to submitting these applications from people who've done it before. That's really important. And if you're within a supervisory group, it's always good to go to another supervisory group if you can to get their views as well. And don't get disheartened by revisions. They're part of the process almost. I think trainees worry about whether they can be as good a surgeon if they are heavily into academia. The answer is definitely yes for me. Surgery is more about cutting. Numbers are important, but they're not the be all and end all. Don't rush to become a consultant. I think it's important we provide representation on ARCP panels so that there's insight into what academic trainees are trying to do. Remember, academic and clinical excellence is not mutually exclusive, but you have to focus. You cannot be a jack of all trades when it comes to both clinical and academic. I think in the early career, don't forget about patients. It's the people around you that matter the most. Make sure you keep and work with good people, forge networks, and get funding in. But by all means, keep calm. Don't be like a bull in a china shop. It takes time to establish yourself, both as a clinician and as an academic. And it's a long process. I just wanted to flag these two initiatives just to show that colleagues don't have to be career academics as consultants to develop a significant academic interest. This is an initiative by the MRC that's recently closed. You have to have had an MD or a PhD, have to find a high quality research partner and demonstrate that you have research capability. And importantly, your institution has to believe in you. So they have to allow you to go forward. The MRC will buy back up to 50% of your time. And you can do this anywhere between 1 to 3 years. And this slide was trying to jump, but the British Heart Foundation has a very similar initiative. It offers you up to 1 year or full-time or 3 years part-time, and you can see what they pay for. So don't forget that as a non-labeled academic, as a consultant vascular surgeon, you do have the opportunity, if you've done enough in the past, to develop an area of research. It used to be that collaborating with industry, if you were a serious academic, was a no-no. Those days are long gone. Industry relationships are encouraged. And particularly as vascular surgeons, I think we have an opportunity to do this because of the nature of our practice. Industry can be a rich resource, but I think there needs to be independent and honest academic scrutiny where thinking about what they want and what you want. So again, you have to be discerning, and you have to find the right people within industry, I think. You have to find people who are honest, focused, efficient, expert, almost impartial, even though they have to represent a money-making machine. But there are people out there that are genuinely interested in finding answers. And again, as I say, the right type of interaction is really encouraged now. And the other thing that I thought would be interesting to point out, again, it's about career variety, is that another offshoot of academia is if you're interested in entrepreneurship, there are plenty of opportunities for that. And you can see so much so that the British Heart Foundation is devoting a whole meeting to it, and you can see a Nature article there talking about how academics spin off companies, and there are significant opportunities for entrepreneurship. But again, it takes planning, it takes focus. You need to think about these things from an early stage. Just coming up to the next, to the last two slides. And what about later on? So hopefully I've illustrated how you develop and you've got various opportunities to get into academia as much or as little as you want. I think later on it's about building excellent teams as a senior academic, perhaps even towards the sort of mid to late career stage. You want to leave a legacy. You want to empower others. I think that's one of the greatest pleasures of being an academic, and being an advocate for the trainees, I think, is very important, and represent the speciality on committees with the grant funding bodies that can make a real difference as to how much success we have as vascular surgeon. I think as we get to be senior academics, that's very important. So the last slide, why academic surgery? Hopefully I've convinced some of you that it's a very rewarding thing to go into. There's no doubt that it gives you an additional skill set. It gives you confidence as a trainee. It gives you expertise in a focused area. I think that it's the only way that we can make novel advances and improve the evidence base is to engage with academia. It's pleasurable to work in teams and to learn leadership and lead. There's no doubt that mentorship at an early stage is useful, and later on that develops into advocacy for others. And as I've said, there's no doubt that academia helps you progress your career, and it gives you a more varied career as a consultant. So these were my thoughts, and I look forward to the discussions. Thank you.
Great, thanks, Bijan. That's a fantastic tour around academic vascular surgery in about 25 minutes. There's a huge amount to discuss. Just to give everyone a reminder, so you can ask questions via the Q&A box at the bottom of your screens. And whilst we're waiting for people to ask questions, Bijan, so there will be those people who are already on an integrated academic training pathway, and we can talk a bit about that in a few minutes, but what would your advice be for a specialty trainee who, I don't know, perhaps goes to St Thomas's or Leicester and thinks, actually, yeah, I'm really quite enjoying being part of this kind of academic environment? How would you encourage them? What would your sort of advice be to that sort of group of specialty trainees to get involved in research?
So I think a high proportion of trainees in our speciality do a higher degree, don't they? So I think the first decision that you need to make as a trainee is whether or not you want to undertake a higher degree. And the approach is almost different according to how much you want to get involved. I mean, I think the foremost advice I can give is to talk to people. Is to approach the people who you think can advise you regarding projects, regarding how to take things forward. And they will suggest, and you can interact with them, and it's always flattering to be approached by people, so don't hesitate to do that. The advice I would give with regard to the practicalities of the work, pick a project within the team early on, demonstrate that you've got the abilities to do the work, and if you get on with that, then, as I said, plan a year ahead. Go and talk to the supervisors, look at what's around in that department, pick a project that you like, ask them what their plans are to take the project forward within 2 or 3 years. Get it down on paper, hypothesis, aims, methods. It has to be specific, and get on with it. That would be my advice.
So we're getting some questions in now. One from Anna. How do you stay motivated in an academic career, Bijan?
Very good question. For me, it's the things that you accomplish along the way. So it's the fact that the PhD student writes up and gets awarded their PhD, securing grants. That's big wins like that. Publishing papers, interacting in meetings, seeing your student up there presenting a really nice piece of work that he or she has spent 2 or 3 years of hard graft accruing data for. There's nothing more pleasurable than that. And then getting patted on the back for the way that he or she presented, and I think those are the big motivations. And building a department as you get more senior. It's the goals and what the wins that you secure. But it's hard work.
And Mohammed's asked a question: is it ever too late? Can you be too old to consider the academic pathway?
I don't think it's ever too late. So this is the reason I pointed to those initiatives as a non-academic labeled consultant from the MRC and the BHF was that that if you work in the right environment, there should always be the flexibility to allow you to do that. I think it's a judgment call. There's no doubt that the things are cumulative. right? So the earlier you start, the more you can build on. But I think if you're interested in academia, perhaps you can't do it to the same extent, but it's never too late.
Bijan, you sort of touched on the need for academic work as part of the CCT, and particularly about the 3 papers. And there will be some specialty trainees perhaps out there who are coming towards the end of their training and thinking, my God, I've suddenly got to get 3 papers for CCT. What advice do you give for those trainees in that situation? Perhaps Thanos might be able to talk a little bit about how collaborative research might work in that regard later, but from your side, how, you know, if a trainee comes to you with that sort of difficult situation, how would they approach that best?
So we're almost talking to the, preaching to the converted, because the people who have registered for this are interested probably on building early. My first advice would be don't leave it late, because to actually complete the work, have it submitted, go through the revisions, and revisions are half of the course, takes time. So that would be the first advice, to plan ahead. The other would be, and again, as you said, Thanos will touch on this, work with teams of people. And that means that you are more likely to have an output. So think about papers early, approach people early in your training, and look to see how you can collaborate with others and join with a team.
And Mr. Garnham tells me via private message that the GMC has removed the need for papers from the new curricula. Do we want to comment on that? Would you like to comment on that, Bijan? Do you think that's sensible? Do you think that's an appropriate thing to do?
It wouldn't surprise you that I do not approve of that. I mean, you know, I think that research understanding and understanding of the process is important for every single vascular surgeon. I really do, who is a consultant, and could have a contribution that, you know, everyone can have a contribution at different levels. I think we have to be familiar with the research methodology at the very least, and with the process of gathering work together, submitting, going through the revision process. So to have a 0 requirement, I'm surprised and alarmed, and I'd be interested to know how that compares with the other specialities. Is that across the board?
I'm not sure whether Andy Garnham wants to comment on that. I'm not sure, Bijan, myself about that. I'd heard there were changes, and I'd heard that they were, I was obviously aware that there were differences among the surgical specialties. But yeah, I certainly am kind of concerned by that. Just tell me what your thoughts, or just share with us your thoughts on the ability of a sort of standard 10 PA vascular consultant, on the ability of her or him to develop an academic career within a full-time post. Is that realistic anymore? Because clearly when you and I were trainees, there were a lot of very academic but very clinically busy vascular surgeons doing the effective the same as a 10 PA contract. Do you think that's realistic anymore?
I think it's really hard, and I think it's really hard because we're a craft specialty, right? You know, but you know, when I look around, it's easier for consultants who aren't in a craft specialty, and I've seen some that have reasonable outputs. I think you can contribute to research as a 10 PA clinical consultant, but if you have a specific piece of work involved in mind that is substantial, I don't think you can do that in a 10 PA clinical contract, which is why I welcome these initiatives by the MRC and the BHF. You need to have some dedicated time set aside, and the right, you know, support as far as resources is concerned to do it.
So just fine. Well, there may be one more question, but just finally, Keith Jones, who is, as far as I'm concerned, one of the font of all sort of vascular education knowledges, tells me that the research requirements related to the understanding that Bijan describes. The removal of the paper numbers is to bring into line with other specialties, and vascular was the last holding on to the requirement. So I guess we're perhaps not moving with the times, but maybe something for Thanos to bring up in terms of the collaborative research and other evidence for research involvement would be useful. Bijan, I think we've probably reached the end of time, so thanks very much for committing to a sort of a Monday evening. That's really great. So now we're going to dip into basic and translational vascular research by Janice Choi, who's Professor of Vascular Surgery at the Royal Free. Janice, welcome.
Thank you very much, and thanks for the invitation to speak here today. Now that Bijan's convinced everybody to do academic vascular surgery, I'll try and convince some of you to at least look into basic science and translational research. So what do we mean by basic research and translational research? I think the definitions are more blurred now. In the past, basic research primarily describe research as looking to increase knowledge, looking for new knowledge, but may or may not have clinical relevance. But these days, sort of doing esoteric research to answer specific esoteric questions are rarely done. So most people set out with a clinically relevant question in mind. In the sort of field of vascular biology, this is usually at the cellular and molecular level. And then after that, there's translational research where we apply new knowledge, technology, materials, or tools to the diagnosis, treatment, and management of disease. And really, basic and translational research incorporates all the stages, I think, that take new discoveries through to clinical application. So in my lab, my work, the basic science component tends to be vascular biology or wound healing work, which is very lab-based through to sort of early animal models. I also do some translational work or cross-disciplinary work where I'm working with material scientists and engineers and other disciplines to see if we can take things into the treatment of vascular disease. So what are the benefits of doing sort of basic science and translational research? Well, we increase knowledge, and the important thing to do is to increase relevant knowledge. And by increasing our understanding of perhaps pathogenesis or pathophysiology, we can lead to new therapeutic targets, new biomarkers, towards sort of looking at prognosis, personalized treatment, and also towards prevention. So here's an example. We all use antiplatelets in the management of cardiovascular disease. This is considered standard care. There might be some debate as to what is the best regime now in primary or secondary prevention. Should we add an antithrombotic therapy? But where did this all come from? Well, you may remember some of the landmark trials done with large numbers of coronary artery disease back in the 80s. And subsequently, there's been various meta-analysis looking at what is the best way of managing the risk factors of our patients using antiplatelet therapy. But looking back, even before that, what was the rationale for these studies? Well, it came from Sir John Vane's discovery of prostacyclin, which is synthesized by Fesselwald to inhibit platelet aggregation, and for this work he was awarded a Nobel Prize. He also found that vascular damage led to platelet aggregation and thrombus formation, and that aspirin was able to inhibit this. And all this work, you may remember some of these in your early undergraduate days, doing experiments that probably didn't quite look as neat, but all these were done with bioassays, tissue and cell cultures in the lab. Looking at another example, I think restenosis that Bijan talked about, drug-eluting balloons. This is an example of something that's developed to tackle a very clinical problem. But what are the components that have brought us together to develop a drug-eluting balloon? Well, it's the understanding of what happens with restenosis and interval hyperplasia, the understanding of antiproliferative and other drugs that might be of use, and also drug delivery systems and materials for the carrier, coating, and the delivery of these drugs in the vasculature. But of course, we know a couple of years ago, this meta-analysis caused a lot of anxiety, finding increased mortality when associated with the use of these devices in the peripheries. And this led to a critique of the paper, a review of data, patient levels data, and various studies, as well as a review of the preclinical data that led us to these clinical studies, and to see if the signal is real. And is there a biological rationale for that? And if there is, perhaps this is where we need to take the question from the bedside back to the bench to understand why, so-called reverse translation. And at the same time, people are already looking at alternative drugs, better delivery systems to try and reduce any potential risk. So why should vascular surgeons look to do basic and translational science? Well, I think we're in a very good position to answer relevant questions in vascular surgery. So we understand the clinical problem, what is the disease, what are the current challenges, and what are the limitations. We understand the ethical issues. So what are the ethics associated with potential new strategies of treatment, as well as the ethics of conducting research on real patients. We understand or can explore acceptability of new treatments with our patients, also acceptability to clinicians and also to the public. And we're in a good position to bring together cross-disciplinary teams so that they can bring together their knowledge from other disciplines towards a clinical solution. We're also well placed to think about how any new solutions might fit in clinical practice. And so I think we can guide other enthusiastic researchers who may want to jump through to new inventions fairly quickly without taking into consideration some of the concerns here. Well, what are the benefits to us? Well, we're exposed to new disciplines, new knowledge, and new skills. And it really is a nice change or a sort of a synergistic thing alongside clinical work. You get to work with a whole range of people. So not just vascular surgeons. I'm not suggesting working with vascular surgeons alone could be boring, but you can work with vascular biologists, engineers, other scientists, and it can be very refreshing. And also to see how they might challenge you to think differently in terms of, say, study design or what is possible in our work. In terms of lab-based projects, I think potentially they're more controllable. You're not relying on recruitment of patients turning up, or other healthcare professionals. So you may be able to control your time a bit better, but some of you might know looking after cells and animals can also be very high maintenance and require a lot of organizational skills. But as a sort of clinical research fellow who may be doing part-time on course or other clinical commitments, it does allow you to plan to a degree how you might fit in your research. You might also have a little bit more control over the direction of your work. So you may be joining a part of a program of work, but within the area you're working at, you may find new findings or new areas that you want to explore further. And you tend to, even as a sort of early research fellow, be able to take on particular areas, looking for new answers. You may have to troubleshoot your own models, develop models to answer the question, and that brings a lot of satisfaction. So I think with some of these projects as well, you're again part of a bigger program of work, so you have a more controllable, manageable aspect of the work for your thesis or for your research degree. And that allows you to really learn generic research skills from sort of a start to the end of a project. So from project management to looking for funding. So again, funding pods for lab-based projects are slightly different. They tend to be, in a way, smaller pods rather than large clinical trials where the funding is already upfront assigned or at least allocated. So you may have the opportunity to look for funding for particular areas that you might be interested in. And all that also leads to the fact that you're more likely to be able to deliver a thesis or a dissertation that stands alone as a very, very satisfactory scientific piece of work. So negative data is still important. Any models that you've developed will still be important, and you will significantly contribute to the overall program of work. But there are some negative aspects. What are the drawbacks? I think increasing, Bijan touched upon it. As with most of the work, there's increasing rules and regulations and admin, and that tends to bog down some of the clinical academics you see, and within the craft specialty where you're also managing your clinical workload, it can be overwhelming at times. And perhaps with some of the lab-based projects where you're running in vitro and in vivo experiments, it's actually harder for clinicians to dip in and out of. So I think one of the questions before is how do we manage this? I think with some of these projects, you are looking at dedicated academic time to be able to do that. So I don't want to end in a negative note. Thank you. That was a quick summary, and I'm happy to answer any questions. Thank you.
Janice, fantastic overview for us. We don't have any questions just at the moment. So if I can start, obviously, it's about 2005, 2006, the NIHR was introduced to, I guess, develop a sort of health research system in the NHS. How's that impacted upon the desire and the amount of translational research that is being done within sort of clinical medicine and vascular surgery, do you think?
I think increasingly you have to show that any research that's done is translational, and I actually don't think that's too much of a problem. I think even before that, as I said, we're actually very rarely doing irrelevant, non-clinical type research. So even your basic lab-based research has a clinical end goal. And I think with the focus on doing translational research, it actually helps us think about timelines a bit better, when we're coming to deliver impact. So it's focused the mind as opposed to change the practice, I think.
And Bijan mentioned about almost the dirty word of industry. Just tell us a little bit about your interaction. You sort of I guess, briefly mentioned it. But can you just tell us a bit more about your interaction with industry and how that relationship works?
So I think with some of the more materials type work, devices work, it's collaboration with industry is really important. First of all, they have the funding, they have the experience. Very often they also have models that they can share with you. So for example, we may have ideas for new stent graft designs or new drug-eluting delivery systems, but some of that work, the background work, is already available. So getting in touch early with industry is important for knowledge exchange. But usually earlier on, industry would like to see proof of concept before they really take on officially any idea, but they'll be happy to give early funding to start projects going. So there are a lot of fellowships that are joint industry, academic type fellowships for usually non-clinical researchers, but there are some for clinicians as well, and they're really good training fellowships as well. So they tend to they tend to give opportunities to spend time in academia as well as in industry. And I think that's important, developing some next generation of researchers that will bridge the two. But the funding there comes with helping with salary, in kind, consumables, with work at the early stage. Moving through the later stage is much harder, and it really relies on solid data and good contracts really with the university.
So Janice, many of the vascular trainees who are listening in perhaps have spent very little time in the lab. They may have been in a lab at medical school or done a sort of integrated BSc or something. But what sort of qualities or skills do you think that you'd like to see in a trainee, or would actually be necessary for this type of basic and translational research? And does it differ from someone who might want to undertake a clinical project?
I think for the lab-based work, any sort of medic's understanding of science gives a very good background. It's not as difficult as you think. Certainly, I think the vascular biology type lab work is probably easy to get an understanding of than something like going into a more engineering type project in terms of material sciences, or even some of the computational studies. I think with those, you really need a strong maths background or physics background or chemistry background. So the biological ones are actually easier for medics to go into. In terms of skills, I think a lot of the lab techniques with sort of pipetting and meticulous running of experiments, I think that's not difficult for surgeons to learn. I think what surgeons might find more difficult to get used to is the sort of time scale of things happening. So we're used to seeing quick results. So sometimes with some of the lab experiments, it takes quite a while to design and optimize the studies before you have your results. And you could have spent a few days planning, 2 days conducting an experiment only for it not to work, and you have to troubleshoot. So I think in my experience, some of the clinicians find it difficult to adjust if they've been doing busy clinical jobs to that. But on the other hand, there's a lot of people to help you in whatever areas. Usually in most research groups, you have postdocs, you have other PhD students. And again, I think as clinicians, you're used to working with people, and that's usually not a problem. So getting people to help and learning from each other isn't usually a problem.
Great, Janice, that's fantastic. So we're now going to hand over to Thanos Zarantzis from Leicester, who's going to talk about collaborative research and research networks, probably something that many of you have heard about and perhaps have been involved in. And before Thanos starts his slides, so I've just received an email from Keith Jones, who's really explained in a bit more detail about the generic research requirements that the GMC have agreed across the surgical specialties. So in effect, trainees must provide evidence of having met the relevant requirements for research and scholarship. And broadly, this includes capabilities in 4 areas. Number 1 being the demonstration of evidence-based practice. Number 2 being understanding how to critically appraise literature and conduct literature searches and reviews. Number 3 is understanding and applying basic research principles. And number 4 is understanding the basic principles of research governance and how to apply relevant ethical guidelines to research activities. I would suggest that you could probably meet all those if you do an MD with Professor Moderai, but you may wish to go down a different track. Anyway, so Thanos, please fire away.
Great, thank you very much. So I am an academic surgeon. I've been through the whole training pathway. I've been an ACF, I've been an ACL funded by the NIHR, and I was very lucky to get an NIHR Advanced Fellowship, which is supporting my salary at the moment as an academic consultant surgeon. So I'll probably try and be a bit philosophical for the first few minutes, and I will probably try and take a step back and do some thinking as to why we do this, why we are academic surgeons. So to start with, I think we probably need to understand and ask ourselves what actually constitutes research. And according to the OECD, and they've produced a number of statements on what is research and what we should be looking at as academics. Research is a systematic activity undertaken in order to increase knowledge and the use of knowledge to devise new applications. And the OECD has also provided us with a sort of pathway, if you like, with regards to what constitutes research. So within the research pathway, one has got to have a hypothesis. They need to conduct an experiment and gather some data, analyze that data, and then come to a conclusion. So this kind of scientific method has been around for quite some time now. It probably started back in Greece about 2,500 years ago. This is the School of Athens. It's a pretty well-known painting, and interestingly, it is in someone's bedroom at the Vatican. What you can see here is practically the origin of the research team, where you've got Plato, who's the old professor, trying to teach his young student, Aristotle, and also trying to teach a number of other chaps about the scientific method, about experiments, about coming to conclusions. And these days, this is the structure, the exact same structure of the usual medical research team, where you've got one professor at the top or the head of department, and then a number of academics who support the professor and support the team, such as registrars or lecturers or medical students, etc. And this was actually set in stone probably about 1,000 years ago in northern Italy, when they first came up with the concept of the university. And again, as you can see, the structure of what constituted the research team back then is pretty similar to today. You've got a professor who's teaching some students, and you've got the professor's disciples, if you like, or the university staff who look really interested, probably because they would like his job. But what I would like you to look at is the students who are actually asleep, some of them. And the other thing about all of those things, the other problem with the structure of those historical teams is the fact that, well, actually they're all privileged males, both the professors and the students. So clearly there are some problems with this kind of structure. And if you think that this is not a problem nowadays, well, this is from about 20 years ago in the Royal College of Surgeons. And as you can see, again, they're all male surgeons, and there's one lady at the center trying to hide. So there are clearly some problems with this kind of research structure. And if you're still not convinced, then this paper about the sun being the center of our universe was published by Galileo Galilei a few centuries ago, and he never actually managed to convince the professors in his various academic institutions that his idea was right, despite the fact that he had very strong data. So I really think that the traditional research structures, well, we probably need to have a rethink about them. Now let's get back to the main steps in the research pathway. There has to be a hypothesis. We have to gather some data after an experiment, and we have to analyze that data. And nowhere here does it say that universities should be building ivory towers. The aim of research is to provide the best possible answers going through that research pathway. And I believe that currently we've got quite a few problems as far as the research pathway is concerned in vascular surgery. If you look at the number of people with coronary artery disease in the United States and the number of people with cerebrovascular diseases in the United States, is not very far from what is currently the main problem with our patients, which is CLPI. But there are dozens upon dozens of trials that have been conducted for patients with coronary artery disease and patients with cerebrovascular disease. And there's only just one trial from about 15 years ago that's been completed in CLPI. So clearly there are some issues there. And I think the issues probably relate to the quality of the data that we're collecting at the moment, especially randomized data, and how quickly we can obtain that data, as well as how quickly we analyze that data and come to conclusions. So that's why I think that research collaboratives are quite important. What are they? Surgical research collaboratives came into existence about 10 years ago. The whole process, the whole thing started in Birmingham. There was something called the West Midlands Research Collaborative. So practically a group of trainees, surgical trainees, came together and said, well, why don't we create a network which we lead ourselves with the support of some of our senior professor colleagues in order to run large-scale multi-center audits or surveys to start with, and potentially one day run big clinical trials. And they did it. And now research collaboratives, especially in surgery, they include several professions and several grades. People like nurses, physiotherapists, welcome to take part. Research collaboratives can design, fund, and deliver all forms of both audit and research. And the interesting thing about them is that they're very, very democratic. Everyone can take part, any healthcare profession can take part. And following the success of the WMRC, that's the West Midlands group in Birmingham, in fact, most specialties have now formed one. There's something called the National Research Collaborative, or NRCM. They've got a meeting every year. I would urge you to look at the ACID and the NRCM websites to find a list of all the collaboratives that are out there and what they've been up to the last few years. So let's have a think about why research collaboratives are important in surgery, and especially in vascular surgery. The PREVENT trial came out only a few days ago, led by one of our senior colleagues, Professor Toby Richards. A fantastic trial. The hypothesis was that preoperative iron could potentially reduce, before surgery, the need for blood transfusion and improve outcomes after surgery. Typical RCT, double-blind design, parallel group. It was funded by the NIHR, HTA, a very strong team, an excellent trial. It was published in Lancet only a few days ago. Interestingly, even though this was a great team, it took them almost 5 years in order to recruit less than 500 patients from 46 major institutions. So clearly there's something there going on with the structure of these traditional research teams. Because if you look at the first trial that the West Midlands Research Collaborative managed to get out there, called the Rossini trial, they managed to recruit 760 patients from 21 institutions in less than 2 years. This was also an RCT. It was quite a complex trial. They were looking at whether wound edge protection devices can reduce surgical site infections after laparotomies. And that was about 9 years ago now. So clearly, research collaboratives, when it comes to things like applied research, are very strong in terms of producing results. Now, the WMRC has moved on from that trial. And just look at those numbers. This is Rossini 2. They managed to get this funded about 2 years ago, NIHR HTA, and they're planning to recruit almost 7,000 patients within 40 months. And they're actually ahead of their targets. I can't really think of many networks of researchers that could be as effective and as efficient as this. So clearly, again, these research collaboratives are doing something right. Let's look at what's happening in vascular surgery. VERN is the main research collaborative when it comes to vascular surgery. It was formed about 6 or 7 years ago by a handful of research registrars, interestingly in the East Midlands. I hope some of them are on the talk today. And over the course of about 5 or 6 years, it actually became an international network of researchers. It aims to streamline the setup, the design, and the delivery of audit, of surveys, and research projects of any form. Like I said earlier, it is very democratic. Anyone can take part, any healthcare professional can take part. This is the official statement of VERN. I'm not going to read it out to you. You can find it on the website. And on the previous slide, that's the website address there, vascular-research.net. So you can look up VERN on their website, find their mission statement, and see how you can get involved. Now, I'll give you a couple of very quick examples of what VERN can do. The first prospective cohort study designed and delivered by VERN was the MARI study. 300 patients, national prospective cohort study. These were patients having major aortic surgery, open or endovascular, complex endovascular surgery. We were collecting almost 900 data points per patient over 90 days. Data completion was almost 100%. Again, I honestly cannot think of many networks of researchers that could deliver that as quickly as that. The GIVE project was recently completed by Dave Bosanquet and Brennick from Wales. Again, event projects. It's the largest ever study of surgical site infection and vascular surgery. It wasn't an RCT, I take that, but again, it's a prospective cohort study, international, more than 1,000 patients recruited. It's currently under publication. And then we come to the COVER study, which I hope you've heard about. This is an international study. There's dozens of countries and hundreds of centers taking part. Mixed methods, both a qualitative and a quantitative element. This is probably the largest vascular study ever worldwide. It's a prospective study, and the VERN team were able to set this up within 2 weeks. So the idea was born during a meeting, and then all the VERN registrars came together and produced a protocol. They managed to find an R&D department and set up an international study of this magnitude, supported by anyone who is someone in vascular surgery within 2 to 3 weeks. Again, I honestly cannot think how this could be done otherwise. These are the countries taking part. These are some very early results from the qualitative element of it, which is coming out in the British Journal of Surgery in a few days' time. I would urge you to read it. And most importantly, the tier 2 paper with more than 1,000 patients will hopefully be coming out very soon as well. Vern does other things like the Dragon's Den session every 1 year, where they've now got funding from the NIHR and industry in order to support a couple of projects, £3,000, and get them going. And they work formally in tandem with the Vascular Society to deliver a number of projects. So I think research collaboratives are changing the usual research team structure in many ways. And I guess in some ways that is probably a very good thing. At the same time, obviously, there are many things within that research pathway that I was talking about earlier that can and should be delivered by the usual research structures within universities and big institutions. And I'm not going to lie, I've spent all of my training and most of my professional life trying to get big grants together with Mark Bound, my senior colleague. And like I said, I spent almost all of my time doing that and trying to support research through the usual pathways. But at the same time, I'm now fully convinced that collaboration is actually the future of research, and research collaboratives are here to stay. I'm committing more and more of my time in order to support those networks, in order to support the delivery of high quality research through them. If you think that Vern doesn't actually fit in those traditional pathways, well, here are two very recent examples where we managed to get funding for 2 big projects with the NIHR. The PERCEIVE study is the follow-on from the GIVE project that was delivered by Dave and Vern. And then Ruth Benson and myself managed to get some funding for a CLTI study, which again was completely developed through Vern. Now, to conclude, research collaboratives, I'm pretty sure that they're here to stay. They're a great new tool to support meaningful research. They are very democratic. Anyone can get involved. Are they going to solve all of our problems? No, but I think they're definitely going to provide us with lots of answers to many of our difficult questions in the research pathway. So please do get involved. If you would like to become part of Vern, you can look up Vern on their website. I'm very happy to receive emails from any of you about this whole process. And like I said, you can devote a few minutes a week, or you can come and become part of the executive committee and spend more time doing it. So thank you very much.
Thanos, great. That's quite an inspiring talk. If I was a trainee, I'd certainly be clamoring to get some more information from you about that. And I think it's fair to say, look, you know, vascular surgery has a really strong heritage in collaborative research, going back to groups like the Joint Vascular Research Group. You know, they performed trials on tranexamic acid in ruptured aneurysms, and they looked at rare diseases like popliteal entrapment. So there's a real heritage of this in vascular surgery, and we shouldn't forget that. But moving forward, where do you see the next opportunities, Thanos, for this sort of research? In what particular areas? Where and how can a trainee get in touch with you to discuss that and discuss potentially discuss their important ideas? Yes.
So first of all, in terms of getting in touch, Vern is very open. So go on the website, look up the emails. Ryan, Ruth, they'll come back to you within a few days. And you can get involved in ongoing projects as a data collector, as someone who's going to set up that project locally in their unit. Or if you would like to get involved more formally in the future in the executive committee, then Ruth, who's the current president, can most definitely discuss that with you in great detail. So website, get in touch. In terms of where do I see the future of this? Well, I don't think that structures like Vern, networks like Vern, are well suited in order to deliver basic science or bench type of research, but they're great at getting many patients recruited, and they're great at delivering things like multi-center audits, if you like, or cohort studies. So this is what these networks are very good at, recruiting lots of patients and setting up studies very quickly. And that's why I said it's not panacea, but there's definitely a role for them in terms of getting these trials done more quickly.
Yeah, I think you made a really good point there about, you know, identifying priorities, and this is really a clarion call for all trainees out there on the call, that it's really important you take part in the James Lind Alliance research prioritization exercise, which is coming towards the final stages now, because those are really critically important questions which have been developed by patients and healthcare professionals together. And when you go to funding bodies, they really are very keen to see, is this a clinically important question and has it been prioritized? So really important to do that. And the other thing I would say is that Thanos made a point about the National Research Collaborative meeting. And that was actually that was supposed to be happening in Bristol this year in December, but it is happening virtually this year. The team there are actually accepting abstracts for that now. So please go onto the National Research Collaborative meeting and register. And it's actually quite a useful resource for some of the important things that Thanos has been talking about in his presentation. So in terms of questions, Anna's got a question. She says there are awesome opportunities, and she's sitting her consultant exam. I presume that's the FRCS VASC next month, but afterwards she would love to get involved. So Thanos, you've got a taker already.
Thanks. Remember, as I mentioned earlier, anyone can get involved. If you're a junior consultant, a very senior consultant, if you're a physiotherapist, podiatrist, there's definitely something that you can do within Vern. So this is not a boys' club or anything like that.
Yeah, and I think you know, it's been a really successful model, which has really been part of the Royal College of Surgeons strategy to drive the numbers of clinical research studies happening and increase the recruitment into clinical trials. You know, if you compare vascular surgery with oncology, for example, around about 80% of oncology patients are actually within some sort of trial, and that's a very clear aspiration for us to get to. And there have been some very successful research collaboratives outside of vascular surgery, as many of you will be aware, both within Europe, globally, and within the UK. I think we may have one final question. No further questions. So if there are no other further questions from the team, then I suggest that we draw number 17, Aspire Vascular, to a close. I'd like to thank very much Bijan Modurai, Thanos and Janice for their inspiring talks. Please do get in touch with any of the speakers if you'd like to talk any more about clinical academic medicine, whether that's translational, whether that's collaborative, or whether that's very much more clinically focused. Thank you very much for attending, and have a good evening. Thank you very much.